Hello, good evening, everyone. I welcome you all to today's webinar of SPECT. And today's topic is very, very interesting. It's all about the latest kid on the block in our bone marrow transplant and cell therapy. That's gene therapy. That's what we are going to discuss today. We have a chairperson who's very renowned, Professor Tulika Seth from AIMS. She's one of the top consultants there in the hematology. So I'll request her to chair today's session and introduce the speaker. Over to Dr. Tulika Seth. Thank you.
Thank you so much. It's a pleasure to be here on this platform. This is a very important platform on transplant and many other important innovative things that we have now available to us in hematology. And we're very fortunate to have Dr. Lakshmanan Krishnamurti, who's professor of pediatrics, section chief pediatric hematology, oncology, bone marrow transplant at the Yale University School of Medicine, USA. He's a very important voice, both in the area of bone marrow transplant in sickle cell as well as in gene therapy. And as you all know, we now have several gene therapy approved for sickle cell as well as for thalassemia. And we're delighted to have a recorded talk by Dr. Krishnamurti to start off with, and hopefully he will join us later on. Thank you.
Genetic bone marrow transplant. In autologous gene therapy, we use the patient's own stem cells as opposed to hematopoietic cells from an allogeneic donor. Patients get chemotherapy. The standard in gene therapy is 4 days of myeloablative dose of busulfan. The conditioning regimens for transplantation are a myriad. Could be myeloablative, reduced intensity, or non-myeloablative. The main difference is because there's no risk of graft versus host disease, there is no need for prolonged immunosuppression. This is not a trivial difference. Patients who have a gene therapy typically go home on prophylactic antivirals, anti-PJP, in oral antifungals, as opposed to multiple medications and other supportive care medications that go with them. In gene therapy, stem cells are being modified. Now, currently, most of these modifications are happening ex vivo, but in the near future, there will be in vivo modifications as well. As opposed to this, bone marrow transplant typically does not involve genetic modification of the stem cells. One can arguably say that the genetic modification introduces us an uncertainty which, compared to this, the natural hematopoietic stem cells may behave in a more predictable manner. There may be also long-term risks due to the genetic modification, off-target effects, or due to a viral vector. Since there is no genetic modification and there is no viral vector, allogeneic transplant does not carry that risk. The long-term risks due to chemotherapy are, as you can imagine, similar in both of them. Let's start with sickle cell disease. This is the area where the progress has been quite dramatic. Why consider gene therapy for sickle cell disease? Well, I think the obvious reason is the severe impairment of the quality of life. And here, as you can see, that in patients with sickle cell disease, in pediatric population, sickle cell disease has a quality of life which is only slightly better than that of a patient with cancer on treatment. While in an adult patient, the quality of life is worse than that of a patient with cancer on treatment. I would like to walk you through what happens in the clinic and in the laboratory for a patient undergoing gene therapy. Once the patient is enrolled and considered appropriate for gene therapy and has appropriate organ function to have an autologous transplant, the process starts with autologous stem cell collection. At the beginning of gene therapy research in sickle cell disease, we had the dilemma on how to mobilize stem cells at the time, while we knew that GCSF was contraindicated in sickle cell disease because of risk of very high white count and pain crisis and stroke. There was not a lot of experience with using plerixafor. Since then, plerixafor has become the standard of care for mobilizing patients with sickle cell disease. This is quite a process. Generally, patients get admitted on a Sunday, get a central line placed on Monday, get an exchange transfusion, and then Tuesday, Wednesday, Thursday, go on the stem cell collection floor for undergoing apheresis. That's partly because the target stem cell collection is so high, typically about 17.5 times 10 to the 6 per kilo body weight of CD34. Often patients require 2 to 4 collections. Most of the time in 2 collections, we're able to do that. From a patient perspective, this is not trivial, and one would not have anticipated that as a clinician until one had seen how much patients had to undergo through this. One important point here is the kind of access. Having thought and worked through a number of different access catheters, a short-term Quinton catheter is usually the best to work with the apheresis machine. The stem cells are then sent to a specialized laboratory. This is a rate-limiting factor, and as I anticipate over the next several months, as gene therapy takes off in a big way in the US, that manufacturing facility appointments are going to be a rate-limiting factor, and there is a lot of room for expanding capacity. In fact, stem cell collection is planned after the manufacturing slot has been secured. The genetic modifications are broadly gene addition or gene editing. There obviously are several variations on the theme, but I am limiting myself to the 2 that are FDA approved. And this is the gene addition of a non-cycling globin gene by using a lentiviral vector. As you can see, this is the lentiviral vector with the non-cycling beta globin gene. And the vector transfers the genetic material and then vanishes. There is no replication competent lentivirus in these patients. And this approach was pioneered by Bluebird Bio, and it now goes by the name Lyfgenia. The second approach is gene editing, is using CRISPR-Cas9 to recognize promoters responsible for the globin gene switching. And this gene editing by reactivating fetal hemoglobin is now approved by the FDA and is called Casgevy. Once this manufacturing process is completed, which takes about 4 months, then patients are brought in for an autologous transplant, get high dose chemotherapy with busulfan with pharmacokinetic dosing. And after that, 3 days later, they receive the stem cells, typically stay in the hospital for 35 to 45 days, and then essentially are followed as an outpatient for side effects and for rehabilitation, especially of chronic pain. 95% of the patients are free of pain crisis. So this is the state of the art for gene therapy for sickle cell disease. You have two choices, Lyfgenia and Casgevy. This was the paper in 2022 of the Bluebird Bio study. In full disclosure, I'm an author on this paper and a participant in this clinical trial. This is a very exciting study for a few reasons. Number one, they were for the first time able to figure out how to get a substantial vector copy number, that is, the number of copies of the vector per diploid genome. For the longest time, this had been the rate-limiting step with vector copy numbers pretty close to 0.5. And as you can see, they were able to get some really high numbers. Now, this may not always the best thing to do. Having a lot of extraneous DNA might have implications that we are not totally sure of at this point. The second thing that they showed was that after the transplant, there was a persistent expression of beta globin that was coded for by this laboratory-created non-cycling beta globin gene. And then as you can see that this goes up gradually in its expression for the first 6 months and remains stable over a period of time. The third major finding here was how it impacts the clinical expression of beta globin. As you can see in this picture, red is good, green is bad. And over time, patients developed about 50% non-sickle hemoglobin, 50 to 55% non-sickle hemoglobin. As you know, sickle cell trait is typically 60% non-sickle hemoglobin. So this would appear that this is close to sickle cell trait. Another major finding biologically was the fact that by 9 months, red cells were positive for BA-T87Q. So the distribution of non-sickling hemoglobin was likely pancellular rather than heterocellular. And that's how it may be different from blood transfusion, where by definition, the non-sickle hemoglobin is heterocellular. Again, this has been discussed quite a lot about hydroxyurea as well. So HbA-T87Q stabilized by 6 months and was present in a mean of 85% by 24 months. And the amount of AT87Q was about 15 picogram. And this per red cell, and in HbAs, it's 13 to 18 picogram is what the hemoglobin A is. So we believe that these data suggest that not only the genetically created hemoglobin pancellular, but it is an adequate quantity to inhibit sickling, as it is similar to what one might expect in sickle cell trait. This cartoon shows that severe VOCs, which in this case were about 3.5 per year prior to gene therapy, was 0 post-gene therapy. It's quite a striking finding. 90% of evaluable participants experienced complete resolution. And those with evaluable health-related quality of life scores reported improvements in pain intensity, pain interference, and fatigue. Unfortunately, there were 2 cases of malignancy. We're not quite sure what happened, but this is the reason why the FDA gave a black box warning saying that these patients have to be followed for the long term. These were the two patients who developed leukemia. And then the first patient was a 42-year-old who was part of the early patients, had a very low vector copy number of 0.1. As you saw, we saw vector copy numbers of 2 to 5. And the AT87Q was not 50%, was only 11.9%. But somehow the patient did not have VOEs, though the patient had persistent hemolysis. And then 3 years post-treatment, developed AML. Interestingly, the blasts were negative for the vector. There were multiple driver mutations that are typical of chemotherapy associated with AML, and unfortunately was fatal. The second patient was similar, had a very low vector copy number of 0.05, very low T87Q, continued to have pain, continued to have hemolysis, and 5.5 years later got leukemia. The blasts were vector positive, but the site of insertion, VAM4, which is involved in neurogenesis, has no role in AML. So it's not clear why this person got leukemia. There were multiple driver mutations, so this person is behaving as if they had chemotherapy before. Unfortunately, the complications were fatal. So at this point, we don't know why these two patients got leukemia. Is it related to a leukemic potential from the pressure on cell multiplication because of the cell turnover in sickle cell disease? The answer is not known. The other major approach to gene therapy for sickle cell disease is to reverse the fetal hemoglobin switch to adult hemoglobin. And the first target was BCL11A, which Dr. Shankaran described when he was still a medical student. And reversing this, targeting the suppression of BCL11A can result in increased fetal hemoglobin, which will inhibit cycling of HbS and alleviate manifestations of sickle cell disease. And this was reported earlier last year by Frango et al. In the New England Journal. In their study, 44 patients with sickle cell who had received axi-cel, of them, 31 were evaluable. 93.5% did not have vaso-occlusive crises in the follow-up period. 95% were vaso-occlusive event-free at 12 months. There was one death due to COVID-19. As you can see, the mean VOC-free duration is 22.4 months. This was achieved in the 12-month VOC-free was achieved in 96.7%. This picture again shows what we had seen previously, that the likelihood of VOC was dramatically reduced in patients after transplantation. Another important factor to remember about gene therapy is how long the journey is. In January of 2024, patients that I started after they had been referred to me, they then had to have comprehensive evaluation, disease management, and starting on chronic blood transfusion, collection of stem cells, fertility preservation, and my first patient of the January 2024 group underwent gene therapy in January of 2025. I'll follow this patient once they leave the hospital for a total of 15 years. So gene therapy is not a quick solution. It takes a lot of time. It also gives a lot of time for the patient to prepare for the therapy. there are many patient issues in decision-making. Eligibility criteria have inconsistencies. The FDA says gene therapy is approved for patients who have a history of VOC. Many others may have qualifiers that they may want to add about what history, how many episodes a year, inpatient, outpatient, how many years. About 3/4 of patients report being willing to take a modest risk of mortality and GVHD. This was Eric Kodish's paper from 1991. We don't know what kind of risk they would be willing to take for an autologous transplant, but certainly patients do understand that GVHD cannot be a good thing. Most patients who consider gene therapy do so because of an unacceptable disease burden, the repeated need to seek healthcare and a poor quality of life, the inability to pursue life goals, a recent episode of worsening of disease-related complications, the need to make a major therapeutic decision, or concerns about the long-term consequences of sickle cell disease. There are many pending issues about awareness, acceptance, access. Chronic pain syndrome does not necessarily go away. It's due to peripheral and central sensitization, could be related to avascular necrosis. There may be psychological comorbidities that may be related to and interact with sickle cell. Family issues, again, a big burden of care. We really need multidisciplinary intervention, which it should be, the hallmark of which should be consistency and repetition. My personal goal is for every patient by day 60 post-transplant to be pain and pain medicine free, to live a life to the fullest, free of pain meds, free of restrictions and limitations caused by sickle cell. Briefly, we'll touch on gene therapy for transfusion-dependent beta thalassemia. This is a paper that Alexis Thompson published. Again, there were dramatic improvements in changes in transfusion requirement after gene therapy. This was the gene addition by Bluebird Bio. Here are the outcomes in 22 patients. And as a result of this, Zynteglo, an autologous hematopoietic stem cell-based gene therapy for adult and pediatric patients with beta thalassemia who require regular blood cell transfusions, was approved. The FDA notes no contraindications, does counsel that antiretrovirals and hydroxyurea be held for a month prior to mobilization, to stop iron chelators 1 week before conditioning, and avoid myelosuppressive chelators for 6 months. Casgevy similarly has shown promising gene editing data. Out of 52 patients, 35 were evaluable at the time the data was reviewed. This was used in ages 12 to 35 in the clinical trial, and 91% became transfusion independent. And so Casgevy is FDA approved for patients 12 years and older who have transfusion-dependent beta thalassemia. Briefly touching on other conditions, here's gene therapy for adrenoleukodystrophy. I found this quite interesting because not only they had 32 patients, and they followed all of them for 24 months and have put them in a long-term follow-up study. At 24 months, none of these patients had major functional disabilities. Overall survival was 94%. Neurologic function score was stable compared to baseline. And then 81% of the patients had no major functional disabilities. Unfortunately, hematologic cancer developed in 7 of 67 patients after the treatment with this gene therapy. This raises a big question mark. It may be related to the particular construct, so stay tuned to learn more. Most recently, we have metachromatic leukodystrophy. Very interesting because they not only had 29 pre-symptomatic MLD patients, but they also had a 31 patients cohort in the untreated natural history cohort. And 26 patients were alive, 3 patients died as a result of disease progression. But the R cell level was actually really good, went up by 18-fold. over 18-fold in those with late infantile variant and 5.7-fold with the early juvenile variant. And patients did better than controls, and most developed a normal cognitive development with prevention or delay of central and peripheral demyelination, and this was FDA approved. I will summarize that transplantation of ex vivo modified autologous hematopoietic stem cell offers a potential for transformative amelioration of genetic disorders. Results of early and intermediate term follow-up are promising. Following the approval by regulatory authority, implementation in clinical settings is beginning. This is a very exciting time. Government insurance and third-party payers in the United States and different parts of Europe and the United Kingdom are beginning to pay for these expensive treatments. We will see how all of this pans out in the upcoming months and years. But there is no question that many unanswered questions in access, acceptability, affordability, assessment of outcomes, and adverse events. So please stay tuned. Thank you.
So thank you. That was a really brilliant talk. And I hand over to the organizers for the panel discussion. Thank you.